He will give that wonderful talk on weight-based dosing versus the flat dose immunotherapy drug. So, Dr. Amol, please.
So let me thanks the organizers and Dr. Mishra sir and Dr. Akhil for giving me an opportunity to interact with you all. And I'm Dr. Amol Akhade. I'm quite a few of you may not be knowing me, but I am quite active in the virtual world and real world. So maybe some of them may be knowing me. So I have no conflict of interest to declare. We have a lot of sponsored sessions today, but I have no specific conflict of interest to declare. But I have a lot of interest when I see this slide, which is the top product forecast for 2023. And if you see, Pembro plus Nivo expected sales in 2023 is 44.8 billion US dollars. That means these two companies will achieve a sale of 44.8 billion US dollars by selling only two drugs. And if you look at the correct perception of this number, it is 10% of the total budget of the India for the year 2023-24. Our entire budget for the country is 549.14 billion US dollars. So you have to understand these numbers to get the exact perception that how much money is involved behind the immunotherapy drugs. It's a $1 billion industry. So cost of the eye drugs is the elephant in the room. And unfortunately, no one wants to see it. And the reasons are different. And most of us medical oncologists are like these blind men. Some of us say that we treat only film star and celebrities, so we don't bother about the cost. Some of us say that we treat only rich class patients who pay in cash. And quite some of us say that we get all CGHS patients, we can give Pembro for 3 years. Who is going to ask? Government is paying. But for most of us, please understand that most of our patients are not able to afford even 1 or 2 cycles of immunotherapy drugs. And that is the reality. This all started in 2011, and ipilimumab got approval way back for melanoma in 2011. And then it all exploded. The pembrolizumab is considered as a new paclitaxel. In fact, it is better than paclitaxel. We can use that in colon cancer also. In paclitaxel, you cannot use in colon cancer, but Pembro you can use in colon cancer. So it is like it is being used in each and every solid tumor. You think of the tumor and it is being used. Now, the characteristic of these drugs are quite well studied, and the pharmacokinetic and pharmacodynamic studies about these drugs is well published. And I wanted to focus on the last part, in which if you see for Nivo and Pembro, the dose is proportional for 0.1 to 10 mg per kg every 2 weeks for Nivo. And for Pembro, the dose is proportional over 2 to 10 milligram per kilogram every 3 weekly. Atezo and avelumab also, there is a similar dose range if you see the PK and PD studies. And we all know that the optimal dose is not same as approved dose. Please understand this concept that whatever doses is approved, it did not be an optimal dose. And it is observed for many oral anti-cancer targeted drugs, including abiraterone, lapatinib, ibrutinib, pomalidomide, osimertinib. And recently we have some indirect confessions also. We see Dr. Rajkumar, who was the PI of the study, has very clearly tweeted recently that we studied 2 mg initially, but didn't really want the dose to be increased to 4 mg. But at the time, they didn't listen. They didn't listen. Who are these they? So we have some indirect confession that the dose is ultimately decided by the pharma company and not by the oncologist to do the clinical trials. And the same is true for the IO drugs. This is the original paper published in 2015 by none other than Robert Matzer. He is the king of kidney cancer trials. You name any kidney cancer trial, Matzer is the PI. And this is the 2015 paper. And if you see on the right-hand side, the time to response and ongoing response is almost identical for nivolumab for 0.3 mg per kg versus 2 mg per kg versus 10 mg per kg. And this is the trial published in JCO phase 2 trial in 2015. And this is from ASCO 2019, that there are a lot of studies which has been initially planned based upon milligram per kilogram dosing rather than a fixed dose in all tumors, be it melanoma, be it non-small cell lung cancer, be it RCC, be it HCC. All these were initially was planned by the pharma company itself. But Pembro was launched and was available for initial few years in 50 mg vial along with 100 mg vial. But the 50 mg vial was withdrawn and only 200 mg fixed dose was promoted. And the reasons are beyond science alone. We all know, I have shown you, $44.8 billion industry is behind this. So of course the reasons are beyond science. Now, if you search in PubMed, the weight-based nivolumab dosing studies or weight-based pembrolizumab dosing studies, you get a very sorry number of 16 results or 17 results. Why? The answer is very obvious. Who is going to sponsor such studies? It takes if somebody wants to decide a weight-based study now, it requires a lot of funds, and that is why but nobody is enthusiastic for doing so much studies because there are no sponsors. But is it an essential medicine? If you see the WHO list of essential drugs published in 2021, nivolumab is considered as an essential drug, albeit for metastatic melanoma, but it is in the list of essential medicine, and Pembro is considered as an alternative. There is another paper published in Lancet in October 2021, and they asked the various medical oncologists to name the list of drugs which they considered as essential, and rightly, Pembro is number 4 if you consider as all low income and upper middle and high income countries. If you see in the extreme right, the high income countries considered Pembro as the number 1 essential drug. But in overall, it is considered as number 4 essential drug. So it is an important drug, and the cost saving approaches for that drug is important because this is the data published by Kumar sir and Vijay, and this is a TMH publication. Only 3% of our eligible patients end up getting access to the immunotherapy drugs. Quite few of you may have different numbers, but I am pretty sure not more than 5 to 10% of eligible patients in your practice end up getting pembrolizumab because of the cost issue. So should we adopt weight-based dosing? We have this publications about the consensus urge. We cannot say that it is a consensus guidelines, but on the call for policy change, it was published in Indian Journal of Medical and Pediatric Oncology, and we have medical oncologists from across various government as well as corporate institutions across the country, various teaching institutions, and we had urged that ICMR should consider for a call for policy change, and pembrolizumab weight-based dosing should be approved along with the fixed dose. We conducted a survey also, similar survey, and we published that results in, again, Indian Journal of Medical and Pediatric Oncology. And we had around 94 participants, and we tried to find out what is the hassle for our oncologists to accept this particular weight-based dosing. And most of the people answered that unless there is a lack of recommendation from regulatory and scientific organization, they will not do it. That means basically everybody is waiting for the ICMR approval for the weight-based dosing to be commonly used. But unfortunately, ICMR requires data, and we have only 2 studies till date of low-dose IO from India. One is from Kumar sir and Vijay about the low-dose immunotherapy head and neck cancer. Another is from AIMS, in which they have used low-dose Nivo for relapsed refractory Hodgkin's lymphoma. But apart from that, we don't have many studies because, of course, getting sponsors for such studies is very difficult. And hence, the situation is like this. The Indian oncology is waiting for divine intervention for approval of low-dose IO. And unfortunately, in spite of a lot of evidences, there is only 2 indications as of today in India where the weight-based pembrolizumab is approved is metastatic melanoma and second line for advanced NSCLC. For the rest of the things, unfortunately, our patients have to pay 3 times Lagan or 3 times the cost, whatever that you want to say. So what is the rest of the world doing? The weight-based dose is already approved in Canada, Denmark, Norway, Israel. It will soon get approved in many European countries. This is a statement published by CADTH. This is the Canadian Agency for Drug and Technologies for Health Recommendations. And they very clearly recommended that what should be the optimal dose for Nivo, what should be the optimal dose of Pembro. And they have very clearly said that the weight-based dosing should be considered for minimizing the drug wastage, for improving the access. In fact, they have given the so-called washout periods also of every drug. And you may have something called as an increase in the frequency, reducing the frequency, that means increasing the gap between the 2 cycles and still have the same efficacy. So smaller countries like Taiwan and Belgium are using low-dose immunotherapy since 2016 and 17, and they have papers published last years. So it is not that other countries are not doing it. In fact, if you see de-escalation trials for IO in advanced cancer, there are various kinds of trials going on. Some are in the suggestion trial instead of giving immunotherapy drugs, still progression on toxicity. Some are saying that can we give it a lesser duration. Some are increasing the extended interval, and some are low dose trial. And it has been quoted that the Tata Memorial trial by Kumar sir, which is called as the CTRI Delhi trial, in which is low dose new versus chemo, which is the proposed trial, the next trial which is coming from TMH. So there is a lot of work going on to get a so-called documentary evidence that the low dose works. Now, is it that some people say that sooner we have generics? The same thing happened palbociclib. No? Palbociclib was around 80,000 by December 2022, and in January end 2023, it has become 4,000 rupees per month. So, is it that the same thing will happen with nivolumab by 2026? We'll have generic. This is very less likely. As I told you, there is a $1 billion industry behind this. Merck has already posted clinical data on subcutaneous Keytruda. And that means they are going to propose now the pembrolizumab should be used as subcutaneous form, and that is called as an evergreen of patent. Same thing they did with trastuzumab, pertuzumab on the subcutaneous form. Once the patent of the IV form is coming to close, so they don't let the golden goose die so soon. So what is the way forward for us? I urge everybody to use weight-based dose whenever fixed dose is not feasible. I again repeat that the option of the fixed dose should be given first. If it is not feasible, then the option of the weight-based dosing should be given. Encourage vial sharing and pulling wherever feasible. In our paper, we have given enough data about, or the references about how vial sharing and pulling can be done. Keep records of such data, compile such data, publish such data. Unfortunately, that is the only way forward to get the weight-based dosing approved along with the fixed dose schedule by the ICMR. We need to put collective pressure on the ICMR for the same. We had given an application to the ICMR through a group of member of parliaments who are doctors. There are certain member of parliaments who are doctors. We have given the application to the ICMR through that, but this particular thing needs to come forward to the various top institutions of the country, teaching as well as non-teaching. Then probably ICMR will look into this, and this is very important. And so we are in the banks of the holy city of Varanasi, which is on the banks of River Ganga. And I don't know how many of you are aware the story of Bhagirath, the King Bhagirath, who took immense efforts. He did a lot of tapasya to get the river Ganga, goddess Ganga, from the heaven to down to the earth. And we will require similar Bhagirath efforts to get an ICMR approval for the weight-based dosing for IO drugs in India, so that IO drugs are available to many more of our patients. And for that, we require coordination for all of us. Thank you. If there is any question, I finished early. Thank you. Oh, sir, no, sir. Because this is, see, I have shown in our survey, the oncologists are reluctant to use in our country the weight-based dosing unless there is an approval from a lack of recognition of regulatory and scientific organization. 46% oncologists feel that unless there is an approval, they are hesitant to use it. The approving authority is not DCGI. Approving authority in our country is ICMR. DCGI says unless and until somebody gives us the data, we cannot act on the data. So the only person that can give an approval is ICMR. The same thing happened for COVID vaccine. Who gave the approval for COVID vaccination for all is ICMR approval. So the same way, we want an ICMR to give an additional approval to along with the fixed dose.
So I think that approval will only impact or make probably the pharma companies to give the PAP to the patients based on that dosing. That is what my understanding is. Because otherwise, all our oncologists are free to use.
Yes, but they are reluctant. As per our survey data, they are reluctant unless and until there is an official approval, because people are worried about the so-called medical legal implications. If I offer somebody low dose, and if a patient goes to my other colleague, and my colleague may say that your disease has progressed because so and so person has used low dose. So that is why people are hesitant to using it. According to me, it should be offered. And it should be well documented that the fixed dose cannot be given, and hence the low dose is being offered. And there is enough PK/PD studies to show that they are equivalent.
I think that is perfectly sound. What you are saying is perfectly sound. And I think most of the oncologists